Thank you, Mr. Chairman. Thanks for holding this hearing, and thank you for letting me join the committee, mostly for purposes of introducing John Colmers, who's now the Secretary of the Department of Health and Mental Hygiene in Maryland under Maryland Governor Martin O'Malley. From November 2000 through January 2007, Mr. Colmers was a senior program officer for the Milbank Memorial Fund. This fund is an endowed national foundation that provides nonpartisan analysis, study, research, and communication on significant issues in health policy. Before that, he spent 19 years, and this is how I came to know him, in Maryland state government, where he held various positions, including Executive Director of the Maryland Healthcare Commission and the Health Services Cost Review Commission, which is the agency that oversees Maryland's all-payer hospital rate-setting system. He has a BS from Johns Hopkins University and an MPH from UNC Chapel Hill, and is past chair of the steering committee of the Reforming States Group, a bipartisan group of executive and legislative leaders. I practiced healthcare law for 18 years in Baltimore, and John Colmers was always somebody who had a stellar reputation. I can't think of anyone better suited to speak to the issues you're addressing today than him. Thank you very much.
Thank you very much. Chairman Andrews, Ranking Member Klein, and members of the subcommittee. My name is John Colmers. I'm the Secretary of the Maryland Department of Health and Mental Hygiene, and I appreciate the opportunity to testify before you today on state health care reforms and the challenges posed by ERISA and opportunities to improve coordination of federal and state initiatives. As you've already heard, ERISA was adopted in 1974 with a reasonable goal of allowing multi-state employers to offer comparable benefits across state lines. Preemption, however, has had unintended consequences for states and for large numbers of people with private self-funded plans who fall outside of state regulatory oversight. Maryland has had recent experience in attempting to expand access through a pay-or-play initiative, the Fair Share Health Care Fund Act. My testimony today will offer the benefits of that experience and describe the limits on voluntary efforts in states to expand access. I will conclude with some suggested modifications to ERISA in the absence of broad reform or the granting of state waiver authority. Most state initiatives to voluntarily expand employer-sponsored insurance coverage have attempted to provide low-cost or subsidized product to employers to offer their workers. To date, these voluntary initiatives have had modest success. Several states have created voluntary programs that offer subsidies to encourage employers to offer insurance or offer those subsidized products to low-income workers. For example, in Maine, they attempted to reach near universal coverage by providing new source of coverage for small businesses and low-income individuals. There were significant subsidies offered, and yet to date, the initiative has enrolled less than 20,000 people, well less of the goal that they had established. Many states have passed laws to allow insurance carriers to sell products that do not include all of the state-required benefits. In Maryland, for example, we have a limited benefit policy, and after a year of being offered, only one group has enrolled 10 people. This leads states to consider mandatory approaches. To the extent that these strategies place requirements on employers, however, they run headlong into federal preemption of ERISA. Maryland's experience with the Fair Share Health Care Fund Act is an example. That bill gave employers with 10,000 or more employees a choice. Either spend at least 8%, or in the case of a nonprofit plan, 6% of their payroll on health insurance costs, or pay the difference into a fund that supports the Medicaid program. The act was struck down by the Federal District Court, and the Fourth Circuit upheld the lower court's decision. The state has dropped any further appeal, and while many policymakers and legal scholars have debated whether such pay-or-play approach is allowable under ERISA, it is clear that states attempting these approaches face a long and potentially contentious process with the courts. In addition to legal obstacles, many states face practical obstacles to mandated approaches. Most states have porous borders and need to remain economically competitive with their natives. The only state that has an employer mandate in place is Hawaii, and they have the luxury of thousands of miles of ocean surrounding it. A sustainable strategy to cover the nation's 47 million uninsured is likely to build off the base of an employer-sponsored insurance. While state reforms should continue to be supported, in my view, comprehensive reform that affects employers needs to come from the federal government. However, recognizing that in the absence of national health care reform, states will continue to move ahead with what they can. Congress may consider granting ERISA exemptions. It could, in the meantime, adopt more modest changes that could help states move forward. These might include, 1, explicitly allowing states to apply premium taxes to employer plans. Currently, states have largely leveraged funds through assessments on delivery systems, that is, provider taxes, rather than direct assessments on employers. A federally limited premium tax would allow an assessment to be specifically targeted. 2, allow states to collect data from ERISA plans. Currently, states do not have the explicit authority to collect information on who and what is covered by an ERISA plan, and this is information that is critical for state policymakers to plan reforms. 3, set a federal floor on benefits. A federal floor for benefits or standardization of benefits would assure adequacy of coverage for individuals receiving health care benefits through ERISA plans. And finally, 4, strengthen consumer protections for those covered by ERISA plans. Strong state consumer protections do not apply to individuals covered by ERISA plans. Currently, limited federal oversight is provided by the Department of Labor, and this oversight could be strengthened and enforcement could be coordinated with the states. In summary, states have tried voluntary strategies to encourage employers to offer insurance. These strategies have offered only modest enrollment effects. So far, the courts have interpreted ERISA as preventing states from considering mandatory strategies. In the absence of national reform, there are some more modest changes that could be done. I would echo the Chairman's suggestion that the first and foremost thing that you can do is reauthorize S-CHIP. It is critically important. You should also consider changes to the Medicaid program to make that much more affordable and easier to operate. Again, thank you for the opportunity, and I'll be happy to answer questions.